and a true innovator. And it is truly our pleasure to welcome him today for taking time off his busy schedule and presenting a topic that hopefully is very much aligned with the video we heard earlier. And with that, Peter, I see you're already. We are so delighted to have you. Thank you for being here. And Kathleen will take it right after your presentation. We have hopefully a little bit more time for chatting, and maybe we can bring in Kathleen some thoughts from the video as well, and the dialogue that will happen afterwards. Without further ado, Kedar, should we advance the slides for you? Or you want to do yourself?
I've got them. Can you see my screen right now? Can you see it? Okay.
Yes. We do.
Okay, very good. Well, thank you so much. And let me just check, Clemens, Barbara, can you hear me as well? Okay. Yes.
Yep.
Okay,
loud and clear. Thank you.
Well, what a joy for me to be part of this conversation. I wish, of course, that we were someplace together and able to do this in person. But I'm so thrilled to be part of this discussion today, and I'm honored to have the opportunity to listen to that testimonial. I was on to see the video, and such a wonderful video. So thank you so much. It gives me a little bit of insight into what you all have been doing here in this collaborative over some time now. But let me say thank you to Clemens, Barbara, Shay, and others who have invited me into this space and into your conversation today. It was great to hear what you're working on. And I want to talk a little bit about this notion of trust, and I'll explain why in just a few minutes. But you could hear it actually in the testimonials that we just heard from the colleagues that were in that video. There's so much about how the teams built trust, how people that were in the video learned to trust their own instincts, and indeed how the wider community of patients and families and the wider community actually saw the individuals in the presentation as worthy of trust and in fact part of the care and treatment team. So it's just a great example of, I think, how trust matters. I can probably end my talk now, since it's clear to me that you all already understand this very well. But trust is also extremely foundational, as you can imagine, to creating not only better care, but also to creating the kind of equity that I think we hope for in healthcare today. And I wanted to start by describing to you something that happened at IHI, and Clemens briefly mentioned IHI, but maybe I could just share a little bit more about it. You may all be very familiar with IHI, but it's been around for 30 years now. The Institute for Healthcare Improvement, started by a gentleman who asked us this question in a staff meeting one day many years ago, Don Berwick. And Don, as many of you will know, is sort of one of the inspirational founders, really, of the field of quality in healthcare and in safety in healthcare. And as I was mentioning, I was in the audience when Don posed this question. We have every year at the start of the calendar year, as we come back from winter holidays and the New Year's holiday, in the first week or two of January, the entire IHI staff gathers together in Boston. We haven't done this over the last couple of years, as you might imagine, but we would gather together and have sort of a time together, just being together and asking each other hard questions and thinking about the year ahead. And Don Berwick, in one of these meetings, this is probably about 10 or 15 years ago now, asked the staff this question. He put this up in the staff meeting. He said, what do you want from your healthcare? And he invited us all in our tables and around the room to answer this question. And as you might imagine, a lot of people said that they wanted to feel healthy. They wanted to feel good. They wanted to have healthcare be available to them. They wanted it to be accessible. They wanted care to be to help them when they needed help, to save them if they had an accident or an injury or a malignancy or otherwise. They wanted to be helped when necessary. And otherwise, people largely wanted healthcare to get out of the way. So they wanted to feel good, be healthy, save me when I need it, be accessible, but otherwise be in the background a bit. Don then put this slide up. He said, what do you really want from your healthcare? So the first question led us to one level of understanding of what people wanted from their healthcare. But as we started to talk about this a little bit more in our staff groups and on our tables, we started to get a little deeper into what people were really wanting from their health and from their care. And the answers to this question started to get a little bit to be qualitatively different than the answers to the first set of questions. It wasn't so much about feeling healthier or having care accessible or otherwise. It started to be about seeing grandchildren grow up, getting to a birthday, being able to make it to our kids' soccer games. That kind of stuff started to be a bigger part of the answer. I wanted to achieve some specific life goal that people had. And then Don asked us this question. What do you really, really want from your healthcare? And it wasn't exactly glib, but again, around the room, the conversation went another level deeper. And the answers became about being heard, being listened to, being helped, being treated fairly. The themes were much deeper. And the room changed from a conversation that was animated and excited. There was still a lot of animation and excitement, but it became there was tears. People were crying. It was a very different conversation. That what people were looking for from their healthcare wasn't just a sense of feeling better or having their condition treated or better managed, but it was about compassion. It was about kindness. It was about being seen, being heard, being helped when you need it. These were what people were asking for from healthcare. It was about justice and compassion and kindness. And these elements were functionally different than what we had been talking about in the first answer to the question that we had. I bring this up here because, we've over the years have manifested many different definitions of what quality means in healthcare, and the field of quality, of which all of you are a part, has grown massively in importance over the past 30 years, stimulated by colleagues like yourselves that have been applying PDSA cycles and other change management mechanisms and made it real, lasting, and important improvements in the lives of patients, family members, and ourselves. Many of you will know that the National Academies of Medicine wrote 2 papers, 2 Eras Human, and in which we first identified challenges to quality in healthcare, and then crossing the quality chasm in 2001, in which we established definitions of quality in healthcare, some of which you can see here in the upper left quadrant of this slide: safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Since this time, since 2001, every major health system not only in the United States, but indeed in most countries in the world, have established quality departments or quality offices or quality agencies. And this sort of promulgation of definitions of quality has become quite a phenomenon. And while there are many definitions, my favorite definition of quality comes from a paraphrase of one of the leading scholars of quality, which is Edwards Deming. He wrote, and again, I'm paraphrasing a bit of what he said, that quality is the degree to which the outcome that we create through our hard work and our effort matches the need of the people who we are intending to serve. This is perhaps in some ways the simplest and I think the clearest definition of quality that I've ever heard. So what do people need, you might ask? And in survey after survey that we've done and that others have done, we find that the essence of what people need are these 3 things. And it gets to the answers to that final question of what we really, really need from our healthcare. And it's these things: help me, don't hurt me, and be kind to me. These ideas of effectiveness, help me, safety, don't hurt me, and person-centeredness, be kind to me. These are the essence of what people describe in survey after survey of what people really need. Underpinning all of these, anchoring these, is a sense of fairness, a sense of trust. And that's why I want to spend a few minutes here today talking about trust and how we create trust and how we manifest trust in our systems, how we sometimes undermine trust in our systems, what threatens it, what builds it, and how does our work in quality contribute to either building trust or potentially unraveling it. I'll start with a story of a patient of mine. This is someone I met, gosh, now 25 years ago. It's hard to believe it was that long ago. I first met Gloria before I became a physician. I was a community health worker in Providence, Rhode Island, something that some of you who were just on the screen a moment ago were sharing your own experiences of that experience. So I was in Providence as a community health worker, and Gloria was one of my patients. Gloria had been diagnosed with HIV. She had progressed to AIDS. And for the first few months, she was very, very sick. She was precariously ill. She had a very fragile immune system. Her physicians had made a deal with her. They would prescribe her a cocktail of aggressive antiretroviral medications that would have the potential to save her life, but she would have to take her meds under supervision. And this is where trust comes in. The system, as we had articulated at that time, didn't actually trust Gloria to take the medicines on her own. Instead, Gloria's doctors wanted to make sure that she was taking her medications religiously, reliably. And I, as her community health worker, was to be that supervisor, was to be those eyes of the system, watching to make sure that Gloria was taking her meds. Gloria, of course, was desperate for these medications. She, for her, as many of you will know very well, in the 90s, this is early, mid 90s, she was, these were the difference between life and death at this time. And as a mother of 4 kids that all depended on her in turn for their survival and their livelihood, Gloria, with her limited resources and limited options, absolutely agreed to participate in this supervised therapeutic program for her access to antiretrovirals. So I began to see Gloria every day for her morning dose. And this was a very chaotic time as she tried to get her kids ready for school and childcare and get herself ready for work. And I was definitely a nuisance to her. I was definitely difficult, but she tolerated me with compassion. And I was doing my job of ostensibly supervising her medications, and she was doing her job faithfully in taking them. She took her, at that time, 23 pills. I remember this so vividly because these pills were giant. Many of you will know this. And she took these pills in 3 handfuls every morning. And I remember this vividly because it was so painful to watch her wince with every gulp that she was making to take these pills down. But she and I did our work. She completed her task of gulping down her pills, and I documented that she was doing it. Gloria was deeply afraid of her disease. She was very fearful. This was a time when a lot of folks were still dying, despite the fact that there was antiretroviral treatment available. Many of her colleagues in her community who suffered the condition were dying of it. And she was concerned about what might happen to her or her family if she didn't make it. She would ply me for information on her condition, and I'd tell her as much as I understood about HIV and AIDS at the time. And she would tell me sometimes that she was afraid that her employer would find out about her HIV status. She had to store some of her medications in a jar in the refrigerator during her shifts during the day, because she had to take some tablets during the daytime, and she was worried about losing her job if her employer found out. Occasionally, I'd see her in the evening times if I missed her in the morning, and there I'd see this parade of case managers and workers coming in and out of her house, helping one of her kids or herself in some way or the other. And all of us thought, I think, that we were helping Gloria in some way or otherwise, but I'm not sure any of us really were. She was no doubt exhausted by all of us in different ways. One day I had a chance to walk with her on her way to the bus stop. And after the morning pill ritual that we were accustomed to doing, and she asked me why the hospital was sending me to see her every day. And I remember thinking at the time as I was walking with her, how do I answer this question in a polite way, in a way that would make her feel supported? But instead, I perhaps in a moment of weakness, I just decided to level with her. And I said, because they think you're high risk. They think that you won't take your medicines. and they think that you'll develop resistance if you don't take them. In effect, I told her that the system didn't trust her. And my role as her community health worker, as somebody overseeing her medicines, was in fact an extension of the health system that didn't really trust Gloria. And she, of course, already knew this. She was just trying to see how much I understood about it. But I tell you this story now at the beginning of this talk around trust because there are so many challenges today. Although this story is, more than 25 some odd years old, we have a problem in our health systems today, even now, of declining trust. And so much of what I see you doing in this collaborative and elsewhere in the video that we just saw was rebuilding that trust through the concerted actions of colleagues that we saw on the video just a few minutes ago. But as we look at it, as I started looking into trust and trying to understand what was happening with trust, I saw pretty stunning information, pretty stunning data on trust. Every objective measure of trust that we have seen over the last several decades has shown plummeting trust in our institutions, in centralized forms of power, in agency and otherwise. All institutions, take media, organized religion, government, all of them are suffering substantial declines in whether the public believes in them or not, whether we trust these institutions or not. In healthcare, the story is no different. If you look at this slide, it's a little bit hard to see probably on your screens, but the blue line is negative views of healthcare and the green line is positive views of healthcare. And you can see for the vast majority of the recorded time since the beginning of the millennium, the negative has outweighed the positive. The 1 year in which this changed was the pandemic year, in which there was a lot of talk about healthcare heroism and a belief in the health system overall as carrying us through the tremendous crisis of the pandemic. But by 2021, just a few months after this initial period, already you can see that the negative is again outweighing the positive. We have a problem of trust declining everywhere. And in many ways, this is leading to the kind of challenge that we see with burnout. Just recently, we've been talking with a colleague here who runs an organization now called Fixed Moral Injury, Dr. Wendy Dean. And Wendy left her clinical practice some years ago now because she felt that she was suffering what she describes as moral injury. Moral injury occurs, as she writes in her work, it occurs when clinicians are repeatedly expected in the course of providing care to make choices that transgress their deeply held beliefs and their longstanding commitments to healing. So this is the idea that when you go to work every day and you know that what you're going to have to do to get your patients what they need is going to be challenging, it's going to be an uphill battle, that's exhausting. And that's the first symptom of burnout. And when you find that you have to do that every day, not just one day, but day after day, and that you're only partially successful at getting your patients what they need, when and how they need it, it also makes you feel ineffective. And that's the second symptom of burnout. And if this happens for long enough, you start to have a hard time watching your patients suffer. And you start to distance yourself from them because it's painful to stay engaged and empathetic when you know that your patients are going to suffer regardless of your efforts. So you start to depersonalize. And that's the third symptom of burnout. Wendy describes moral injury as there being a lot of roads to burnout, but moral injury being the highway to burnout in our systems. And trust breaks down when we thought that those who were supposed to create conditions to enable us to do the work that we were supposed to do of healing and helping is actually failing to help us do that work. So I raised this for you because I started to get quite depressed by all of this as I was doing my research on trust. And I wondered whether or not there was anything we could do about it. How can we rebuild trust? How can we help with this challenge that we see in our patients and our populations today? And I came across this work by a woman named Rachel Botsman. She's in the UK. And her book, Who Can You Trust?, held a kind of an interesting thesis. And what she said was, trust wasn't exactly declining across our social systems and our governments and otherwise. it was just changing, and it was changing very, very fast. In this millennium, in the last 20 years, trust has morphed completely. She said, trust, the glue that holds our societies together, hasn't disappeared, it's simply shifted. And so, and one of the stories she uses to illustrate this point is, consider for a moment, the phenomenon of going to a city that you've never been in before, hailing through your phone a car that's being driven by a perfect stranger, taking that car to somebody's home that you've never been in before, entering that home as part of a vacation rental that you'll stay in for the next week with no threat of being injured or harmed or otherwise, and then taking the car of a perfect stranger back to the airport and then going back home. This is the story that we have right now. We trust these highly decentralized networks like Uber and Airbnb and Lyft and other things to help us achieve normal functions like traveling places and having the opportunity to stay places. What we formerly trusted were brands like Hilton, Marriott, and the New York taxi companies, the Yellow Cabs. But now what we trust are these decentralized, anonymous networks of individuals. And that is a pretty profound change in trust. So I started looking for ideas about how we could build trust and how we could do that in healthcare in the future. And I found the work of a Harvard Business School professor named Francis Frey. Frey had worked with Uber and Airbnb during the time when they were going through corporate crises around trust. And Frey believes that there are three essential components to trust, what she describes as empathy, logic, and authenticity. Empathy: if you believe that my empathy is directed toward you, you are more likely to trust me. If you believe my reasoning makes sense in logic, you are more likely to trust me. And if you believe I am being authentic, true to myself, then you are more likely to trust me. Importantly, these three things, empathy, logic, authenticity, describe both cognitive aspects or dimensions of trust formation, that's logic largely, along with affective dimensions of trust formation, that's empathy and authenticity. Affective trust is the trust in someone's capacity for caring, the idea that you believe that somebody is capable of caring for you. And these three things, empathy, logic, and authenticity, are both where trust can begin and where it can unfortunately break down. So as I was talking with Francis about these, I wondered how we actually practice these things. How do we, these are nice words in a triangle, as it were, but I wondered, how do we actually practice these things? And how might we, in the work that you all do and the work that we do in quality, how might we try to recreate these things and build trust in our communities and in our patients and in our work? And I wondered, what are one or two things that we could actually do in our practices as a quality expert, as a clinician, as a healthcare leader, to help build this kind of trust? So Frey says that the usual thinking around empathy is that we must walk in another person's shoes, walk a mile in someone else's shoes. But of course, that's very difficult to do because I can't really know what it's like to walk in your shoes from where I sit and from my lived experience. The breakthrough she describes in empathy is in the concept of centering someone else's experience, centering someone else, choosing to spend time with another person and getting genuinely curious about what their experience is and has been. And as I hear you talk about some of the work that you're doing and that was in the videos, that's exactly what you're doing. You're centering someone else's experience and getting to know and getting genuinely curious about what that experience has been. I can't walk in your shoes, Frey says, but I can center on you and I can learn about your experience by getting curious. And that process of asking open and honest questions is vital to creating empathetic understanding of each person's situation. The second component was logic. I won't trust what I can't understand. It's hard to believe in someone whose judgment you find suspect, where you can't believe that you don't believe what they're capable of doing. You also, if you can't communicate with them, you can't connect to them, you also will have trouble trusting them. I believe you have the knowledge and skills, and your competence and ability make me trust you. Frey describes instability in any dimension of the trust triangle as a wobble. And she says, when you have a logic wobble, it usually means there's something wrong about the design of your intervention, something about it that doesn't make sense. For example, we ER doctors will see, or ER nurses will see a patient in the ER over and over and over again without asking about the root cause and not understanding the whole story as to why that person is coming in and out of the hospital, out of the ER. If they can't address the root causes, then we start to have a logic problem, a logic challenge. The other issue driving logic challenges is the failure to communicate. I can't tell you how often we make this mistake in leadership. The axiom that we sometimes say about having to communicate 8 times 8 ways is so true and so needed, because as leaders, as people with some agency, you all have knowledge and insight that makes your decisions seem rational and reasonable, but that might not make sense to anyone else. You know, in the case of my experience with Gloria, you know, the belief in the distrust of her might have seemed logical and reasonable for the health system actors or the clinicians, but it absolutely made no sense to her because she felt, of course, that she was perfectly trustworthy and capable. So the whole idea around logic is not only to have a good design, a capable design, but also to be able to communicate it successfully. And then the last dimension, and my favorite, is authenticity. You can't be good at being anyone but yourself, and it's hard to trust someone who isn't their authentic self. Of course, there may be powerful realities that prevent you from being exactly you in every situation, but without being authentically you, trust will weaken and skepticism about intentions and motivations will inevitably creep in. And one of the most important aspects of authenticity is consistency. In survey after survey, what people want from leaders and what they want from their healthcare providers is follow through. They want consistent follow through. Tell people where you're going, take them there, and then tell them where you've taken them in the end. Trust doesn't get built overnight. You've got to listen, really understand, act on what you're hearing, and share with folks how you are acting. And then do that over and over and over again consistently. And perhaps on the 10th time of doing that, people will start to trust you and trust that you mean what you say and you say what you mean. Consistency in the end matters a great deal. So let me just share with you now a couple of reasons why I think trust matters today, and then we'll get to some questions. I think trust matters because it saves lives, literally. And this is a story of someone I met when I was doing some of this research on trust. It's a story of Kyle Christensen. Kyle is a family medicine doctor. He's all the way here on the right, pictured on the right of the slide. And this is his family: Ben, Lars, Jennifer, his wife, and himself. Kyle is a family medicine doc at Unity Point's Prairie Parkway Clinic in Iowa, in Cedar Falls, excuse me. And his wife, Jennifer, and him and their family live in Iowa, as I said. 7 years ago, maybe 8 years ago now, Kyle and Jennifer's firstborn child came out to them as a transgender male. Ben, their son, had experienced years of uncertainty and confusion about his gender identity and had even contemplated his own suicide. But Ben was resilient and persistent, and Kyle and Jennifer made a choice not to retreat into denial, fear, or ignorance, but instead to embrace Ben, their child, and his authentic self and become curious. And they chose to center on their son's experience. They chose to center on Ben's experience. And when they made that choice, they went all in. They learned everything they could about what it meant to be transgender. They learned that a staggering 82% of trans folks had considered suicide at some point in their lifetimes, that a third of trans folks would attempt suicide before the age of 18. They heard countless stories of the medical system denying care, presenting barriers, actively withholding needed care and service for trans people. And with that knowledge, Kyle and Jennifer went to work, and they opened the first of its kind LGBTQ clinic at Unity Point Prairie Parkway in Cedar Falls, Iowa. And they were terrified about doing this. This was a small town, after all, and they really didn't know how their community would respond. They could have caved into fear and inertia, but they didn't. They were motivated. They were driven by Ben's experience, and they found the energy, enthusiasm that they needed to get through their fears. And their energy, enthusiasm was met by energy from all corners at Unity Point. Leadership endorsed the effort. A half a dozen physicians came in, another half a dozen nurses joined, the pharmacy, laboratory, radiology, social work, all came to their aid. In Kyle's words, folks wanted to do this. They just didn't know how. And when they opened the doors ultimately of the LGBTQ clinic, and they welcomed their first patient by asking them what pronouns they use, they were greeted with energy, with enthusiasm. from the community. And now their clinic has mushroomed. They've filled it quickly, and now they've launched 4 additional LGBTQ clinics in different Unity Point regions across the Midwest. Ben, by the way, is thriving, living and working in Chicago for an organization focused on social change. But without that kind of trust, without that development of empathy, authenticity, and logic, this story might have been very different. And when I was speaking with Kyle from Unity Point about the new LGBTQ clinic, he told me about this study, which completely stopped me in my tracks. He said, by the time trans people reach the age of 18, nearly a third of them have attempted suicide. But here's the interesting thing. LGBTQ youth who report having just one accepting adult, an adult who says, I see you and I accept you for who you are in all of your glory, I trust you. Having just one accepting adult in a trans person's life reduces the relative risk of an actual suicide by 40%. And what's amazing about that is the single affirming adult can be anyone, absolutely anyone. And that's why when Kyle opened the Unity Point Prairie Parkway Clinic, he invited everyone in the clinic to go through, from the person holding the door, welcoming you into the clinic. Everyone in the clinic has gone through the training required to demonstrate empathy, logic, and authenticity, because they could become that single affirming adult that creates this kind of life-saving result. Anyone ultimately can build the kind of trust necessary. Trust also creates engagement. It breaks way past engagement, I might argue, towards creating true co-production of care and outcome. This is a story from Sweden, very briefly. This is Christian Farman. Christian was a young man in his late 20s with a end-stage renal disease due to a glomerulonephritis that he suddenly acquired in his late 20s. He was a Saab engineer, and he all of a sudden required a big change in his life. He needed to be on dialysis 3 times a week and in a hospital in Ryhov in Jönköping, Sweden. It is a traditional setup. He couldn't hold a job because he was in dialysis Monday, Wednesday, Friday from 8 a.m. or 9 a.m. till 2 or 3 in the afternoon, and that prevented him from being able to continue in his job. He was a young man, so he said, and an engineer, so he asked his nurse, Britt Marie, if she would teach him how to dialyze himself. He looked at the machines, he looked at the dialysis equipment, and he said, I can do this myself. I don't need, I'm happy for you to help me understand how to do it, but I can do this myself. And Britt Marie, instead of saying no to this, instead of saying you're crazy or putting him off, she trusted him and he trusted her. And they created a completely different way of doing dialysis. He learned to dialyze himself. He learned to self-cannulate. He learned to clean the fistula. He learned to self-cannulate. He learned to hook himself up to the machines. And then as he started to do this, other patients who were in the clinic, in the hemodialysis center, said, well, why does Christian get to hook himself up to the machines and toggle his dialysate? I want to learn how to do that too. So I don't have to come in here at Monday morning at 9 a.m. I'd rather come in here on my own time when I can do this and hold down my job or otherwise. So he taught the next person how to do it. And then soon they had a whole group of patients dialyze themselves. And at this point in time, today, this was many years ago, at this point today, over 70% of the patients in this dialysis center dialyze themselves. They hook themselves up to their own dialysis machines, and they do it whenever they want. The system has produced key cards for them to come in and out of the clinic and dialyze themselves in the middle of the night, in the late afternoon, whatever they want. They have somebody there on staff to make sure that people are able to do it safely. But it's a remarkable story of how to change the way that we do this. Lots of lessons around this. Christian has a new definition of health. He wants to live a full life, care safer in his hands. For Britt Marie, the nurse who trusted him, surprised at the design differences. They're doing it at a third of the cost per patient seen, which is amazing. And they have better outcomes. The care is actually safer in their hands. And if you think this is a weird Swedish story, they're doing it in Texas. This is Central Texas Nephrology Associates. Here are the results in Waco. I saw Waco was in the chat earlier. From this from CTNA. Self-dialysis compared to usual dialysis, the mortality is almost 7-fold lower. The hospitalization is a third of what it is otherwise. There's a bit of selection bias in this, but it's pretty remarkable to see the kind of outcomes that you're able to get when you trust that patients can care for themselves and co-produce outcomes in this kind of way. So trust not only saves lives, as we saw in the story with Prairie Parkway, but it also creates engagement that goes well beyond regular engagement and goes towards creating lasting co-production of outcomes. The last thing I'll say about this is that trust builds community. This is a story from Chicago, those of you that might be there. This is a story from the west side of Chicago, and a partnership between Rush University Medical System and the west side neighborhoods in Chicago, where there's a considerable opportunity for community development and investment and improvement. The community, Rush, invested in an organization, Rush, the health system, stimulated investment in an organization. They helped create this organization called Westside United, that's led by Aisha Jaco, the executive director there. And when I spoke to Aisha about this agency, she describes what Westside United doing as a trust broker. The mayor of the city of Chicago, Mayor Lightfoot, can come to Westside United when there's challenges and issues that they need to sort out on the west side. For example, when COVID was breaking in early mid 2020 in the city, the mayor came to Aisha and Westside United to help with case detection rates, to help with vaccine deployment. The city didn't know how to do those things. It needed a trusted member of the community, Westside United, to help people come forward to get vaccinated, to help build that kind of trust and relationship with the community. And likewise, when the community experiences some harm or some problem or some challenge, they come to Westside United to try to help them solve it. So, for example, Aisha, when I spoke to her, was describing something that happened the night before, where a grocery store in the west side had closed, and it was one of the only grocery stores in this particular part. It was if it closed, it would essentially create a food desert. And instead of not knowing what to do in this situation, the community came to Westside United to help make the case for why this grocery store couldn't close. And then Westside United was able to make that case in the city. So the Westside United was creating this trust brokerage between the community and power, and allowing for transactions of time, money, and resources to flow towards the community to enable it to be successful and to thrive. A version of that was being done in the healthcare environment in Boston. This is work that's done by the Brigham and Women's Hospital, in which they are working on equity directly. And what they're saying is that we need to acknowledge past harms, work on redress or changing the conditions, to take compensatory action, and then work with the community to create alignment and agreement and closure if the harm that was present has been addressed through the redress approach. This concept of a healing arc they've used now in several instances. The Brigham specifically has acknowledged that when Black patients and white patients present to the Brigham Women's Hospital with the same cardiac symptoms, what was happening previously was that Black patients were going to the general medical service, white patients were going to the cardiology service, where outcomes were better and the experience was better. Having understood that problem, the Brigham has now acknowledged that. They have created mechanisms in their electronic health record to, in essence, create a default pathway for anyone with presenting symptoms, regardless of what race the patient is, to automatically go to the cardiology service. And that type of redress is starting to change the dynamic around who goes to what service in time and gets the better care and better outcome. I'll just close with one last comment, and then we can go where you would like to go in questions, which is that the work that you do, quality improvement, builds trust. And the reason I think that is an observation that some researchers, I was giving this talk at one time, and some researchers in Kenya pointed out to me that these plan, do, study, act cycles that we all conduct, and that I know you all know about, we thought of them as a way to test our theories, test our ideas at a small scale. I heard somebody say that in the video, test our ideas at a small scale, and to validate that they would work, to help with the change management process, to help with technical improvements to care processes. I had always understood it that way too, as a quality improver. I'd always understood the work that we were doing as making better and more reliable care processes, creating technical improvements. What I had less understanding of, and did not fully appreciate until speaking with these researchers in Kenya, was that the very change cycle that we use to create technical improvements is also doing something else in our systems. It's also creating adaptive change in our teams. It's building relationship between the members of our teams. It's creating new forms of alliance and affiliation as our teams progress, and as they win, they create small victories and they advance their efforts. There's a very common phenomenon that we've experienced at IHI over the years, which is that often in the beginning of any major change initiative, there's a handful of folks that are resistors, that are not terribly interested in working on the project or the problem. But that resistance we've come to understand not as a problem to be dealt with, but rather as an asset. And this is confusing. Resistance is an asset. And the reason it's an asset is because those resistors are deeply passionate about the outcome. They care a great deal about what's going to happen next. And through the process of PDSAs and quality improvement work, we have seen over and over and over again that resistors ultimately become champions. And that the mechanics of how that happens is that the plan, do, study, act cycle is not only a technical aspect, but it's also an adaptive change management cycle. And it's partnered sometimes with this notion of gratitude and recognition, setting common goals, and aligning individual self-interest. And these two things together create the kind of change that we see in our teams as we do our quality improvement work. So quality improvement not only helps to improve technical process, it builds team and relationship by stimulating trust in our systems and in our teams. So I'll leave you with this last question, and then we can head into discussion or wherever you'd like to go. But as we think about the work that we're doing here, I ask you, in the last month, what's one thing you've seen or done or heard of that you believe has helped to build trust in your work, in your communities, in your organizations, in your environments? And I'll leave you there, and happy to take any questions or comments here now.
Thank you so much for that, Dr. Mate. I'm Kathleen Clannon. I'm an HIV doc in Oakland, and I'm going to be facilitating. We've got just about 5 minutes for some reflections on this, but I think your question was actually a perfect one for us to stimulate some great comments in the chat. One of the things I love about this model is it seems to lend itself very well to both individual level change, clinic level change, and system level change. So if people would please go ahead and write, what is your experience? We can put the question back up again or paste it into the chat if Shami will help with that. And while people are doing that, I wanted to ask you a question. When I first saw the title of the presentation, I was thinking that we needed patients to trust us as a healthcare system. But really a lot of what you talked about is about the fact that we need to show patients that we trust them. And I wonder if you would kind of reflect on that. There's a ton of things in the chat from our peers about reflecting that that is their experience also. So could you just talk a little bit about that two-way trust?
Yeah, it's absolutely mutual. Yeah, there's a lot of mutuality in trust, right? I mean, there's no way, trust is between individuals or between groups or between entities. So there's a tremendous amount of mutuality in that trust. And you're 100% right that a lot of what we have been thinking about or often referencing in the past is how patients trust or distrust us. By the way, I think distrust is often code words for blaming the victim. So I really think a lot of what we heard during the pandemic around distrust from communities and otherwise, not to say that there isn't distrust, I'm not saying that there isn't, but it's a lot of blaming the communities for exhibiting that kind of distrust. And there's a lot of latent laced in or things in this. So I think that's a very risky, slippery slope, if you will. But I will say that I think a lot of, I mean, you can hear in the story of my patient, right, of Gloria, there's so much of what was being architected around that was not trying to stimulate her trust in our system. It was, you know, very much arguing that she was untrustworthy and that the system was explicitly distrustful of her. We had created this whole program to try to mitigate against that distrust instead of believing that there was something that we could do differently that would better meet her needs, better serve her in this particular case.
Yeah, there has been certainly a lot of that conversation around COVID vaccine, and how to engage different communities about that. So it was definitely striking to me to think about that mutuality. Cindy Burton, if you're willing to unmute, I would love for you to ask your question or make your comment verbally, because I think it's really important one also. And Cindy, are you willing to do that?
I am.
Go for it. We can.
Well,
Yes.
I believe that there's mistrust many times in the organizations that are mutually on the ground trying to assist patients. And that is not helpful at all for anyone. And I've been a nurse for 42 years and have worked in all kinds of settings. And I've seen firsthand, what damage that can do to a whole team who is trying to provide care to someone if there's a couple of folks that aren't trusting one another, or you don't trust the group that is the only referral for mental health, so you just don't do the referral. What happens to that? It's just, I think using the same methodology would be helpful for that arena as well.
I mean, all I'll say is that I think it's really, we have to ask ourselves, as somebody said in the chat here, David puts this in the chat, that the existence of distrust or mistrust should stimulate for us some inquiry on why that exists, and rather than casting blame or aspersion on the community that's distrustful or mistrustful, the question is, why would that be the case? And there's usually a pretty darn good reason for it, whether it's historical or present action. There's usually a pretty darn good reason for why that's the case. And unless you deliberately take steps to change that dynamic, past or present, that's hard to rectify. It's hard to make it better, and I think that's it's a lot of the learning around equity, right? To be clear about this, unless we center equity as an objective, as a goal, creating more equitable outcomes or equitable care, we won't necessarily be mindful of the consequences of our really good improvement work. And Clemens shared with me some of the work of this collaborative from the last iteration, the last cycle. So highly encourage publishing it, because then it's there's a record of it, and we can understand and learn from it, and we can spread it. But so much of what you did was explicitly tackling the inequities that were present in the system through the work groups, or I don't know exactly what you call them, but through the subgroups in the collaborative. And that's a way of kind of more explicitly targeting the challenges that we have, targeting the inequities that are present. And that when we do that, we're capable of reducing the inequities. The same is true of trust. When we're conscious of the trust and we try to understand its root causes and challenges, we can change it. That it's not a fixed phenomenon forever to be carried. It's a matter of being more deliberate about trying to change it.
Those are wonderful closing words. I wish we had more time to be able to talk this through, but we do need to end. So thank you so much for that.